Today we are going to discuss about Kawasaki disease. It is very important topic for all India examination because this Kawasaki disease is the most common coronary artery aneurysm in children. This Kawasaki disease is the most common middle vessel vasculitis in children. This Kawasaki disease is the most common acquired cardiac disease in children. So this is very important for all India examination purpose. And this disease is also very important for clinical practice because we frequently miss this disease. And if we miss this disease, the child may suffering from coronary artery aneurysm, and that's why the child may lead to some sudden death due to coronary aneurysm rupture. So please be attention about this disease because this is very important topic for examination purpose and also for day-to-day practice. Now, before going to discuss about the detail of this disease, I have a question asked in All India examination. The question is: a 8-month-old male present with a history of fever for 5 days with irritability and convulsion one episode. There is a high grade fever, and on examination, no significant findings are present except the fever. After admission in hospital, the CBC and LP was done. The CBC report shows leukocytosis, thrombocytosis, and the LP report was normal. After getting ceftriaxone for 4 days, still the fever is persist and the irritability is present. The ESR is high, 45, and CRP is also high. On the day 9, there was a perianal excoriation. An echo report was normal. So, what may be the provisional diagnosis? The options are: the child may suffering from Kawasaki disease, or the child having febrile convulsion, or the child having Kawasaki disease. So, in this question, the point towards the diagnosis is the child having fever with irritability and seizure. That means the child having fever with convulsion at 8 months of age. But the CSF report is normal, but there is a significant thrombocytosis, and the ESR and CRP is high. And also on the day 9, there is a perianal excoriation. So these are the findings which lead the suggest that the child is suffering from Kawasaki disease. Come to the details of the disease. Kawasaki disease was first described in 1963 by Tomisaku Kawasaki, and he diagnosed this disease and he named this disease as mucocutaneous lymph node syndrome. So Kawasaki disease previously named as mucocutaneous lymph node syndrome. Now it is the name has changed. The new name for the Kawasaki disease is infantile polyarteritis nodosa. So the new name is infantile polyarteritis nodosa. That means this disease mainly affect the artery, and the artery which is mainly affected is the medial vessels. So this is an acute self-limiting febrile illness of unknown cause that predominantly affect the age group of less than 5 years. And the medial vessels vasculitis is a specific predilection to involve the coronary artery. It is a middle vessel vasculitis, and the most common middle vessels which is affected in Kawasaki disease is the coronary artery. So these all are MCQs. Now, the most common cause of acquired heart disease in children is also the Kawasaki disease. January 26 is the Kawasaki Disease Awareness Day. If we do not diagnose a patient having Kawasaki disease and the child is untreated with IVIG, then there is maybe a chance of 20 to 25 children with Kawasaki disease can develop coronary artery aneurysm. So 20 to 25% the child may develop coronary artery aneurysm if we do not diagnose the Kawasaki disease. So it is very important to diagnose and know all thing about the Kawasaki disease. And if we treat with IVIG, so drug of choice is IVIG, and if we treat with IVIG, then the chance of coronary artery aneurysm drop from 25 to 3 to 5%. So this is very important to know about the Kawasaki disease very well. Now come to the epidemiology. it is the it is mainly occurred in Asian children, mostly in the Japanese children are mainly affected by this Kawasaki disease, and there is a male female ratio is male is 1.5 is to 1, and Kawasaki disease is predominantly but not exclusively for young children. That means less than 5 years it is mostly affected, but after 5 years the child may suffering from Kawasaki disease also. Now with the etiology. The etiology is really unknown. Some are telling that the disease is occurred after some infectious origin. That means after some viral problem, the child may suffering from this Kawasaki disease. As because some studies show that after some viral infection, the body produce some antibody antigen, and this antibody antigen affect this antibody antigen produce some inflammation and also affect the median vessels and causing this Kawasaki disease. Now, the genetic factor play an important role in the etiology of Kawasaki disease. The most important genes for the Kawasaki disease is FCGR2A gene or Cas3 gene and also BLK gene. This is all MCQs. So the most important genes are FCGR2A gene, Cas3 gene or BLK gene. Now the pathology. As I said, Kawasaki disease is mainly the medium vessel vasculitis, and this disease mainly affect the medium vessels, and there is a involvement of the muscular arteries. Mainly, the muscular arteries get involved by in Kawasaki disease. That means the small vessels and the veins do not have some muscle. That's why they affect the medium vessels, and most common medium vessels which is affected in Kawasaki disease is coronary artery. After that, there may be a chance of having subclavian artery aneurysm or brachial artery aneurysm or popliteal artery aneurysm. And this arteritis is mainly occurred in three processed. First is neutrophilic necrotizing arteritis. That means after the disease starts, the neutrophil get attached to the endothelium layer of the muscle, and they affect the endothelial layer and they cause inflammation, and which after the inflammation they also kill the endothelium and also kill the muscle. That means the artery is having three layers, that is intimal layer, then medial layer and the adventitial layer. They starts from the intimal layer and then kill then destroy the muscular layer, medial layer and then the adventitial layer. In neutrophilic necrotizing arteritis, after the inflammation, the medial layer get destroyed and there is a saccular aneurysm also can occur in this patient. And also during this inflammation, the platelet may attach to the intimal layer and which may causing coronary artery stenosis, and also there is a formation of thrombosis. This thrombus may lost to some different part of the body and can cause some serious illness. So there may during this stage, that means the neutrophilic necrotizing arteritis, there is the child may suffering from thrombosis or may suffering from coronary artery aneurysm, and this process is occur for first 2 weeks after the fever onset. After that, there is a transition from neutrophil to lymphocyte, and that lymphocyte get attached into the medial layer and they cause inflammation. And there is also myofibroblastic proliferation, and which causes there is a stenosis. During this subacute or chronic vasculitis, they may destroy the medial layer and there may be having some aneurysm. This type of aneurysm is mainly causing fusiform aneurysm, and after this there is a myelofibroblastic proliferation and causing stenosis. That means in second stage and the third stage it is a chronic process and which can last for few years to few months, and as a result of this chronic inflammation there is a coronary artery stenosis, formation of the coronary artery stenosis. So in the first stage, there may be formation of coronary artery thrombus or aneurysm. In the second stage, there may have some coronary artery aneurysm, but the stenosis is predominantly. And the last stage, there is also coronary artery aneurysm, coronary artery stenosis. This is the natural history of coronary artery abnormality. So when there is a Kawasaki disease start, there is neutrophilic necrotizing arteritis, which causes dilatation of the arteries because of the medial layer inflammation. So medial layer get inflamed, and there is maybe destruction of the medial layer, which causes this type of aneurysm. And there may be some platelet get attached to the endothelium, and this causes occlusion or thrombosis. That this may cause a myocardial infarction or dislodge of the thrombus to some other part of the body, can cause some serious illness. After this process, when the processes go on, there may proliferation of the lymphocyte in this area, and this proliferative layer is causing stenosis of the blood vessels in the third stage. So this is the normal natural progression of this disease. So the first stage, as I said, neutrophilic necrotizing arteritis. This is consists of synchronized neutrophilic process completed within 2 weeks after the fever. So this is the only self-limiting disease process. That means in this stage only, this if we treat with IVIG, the child cannot develop any aneurysm, and then so this is the stage in which there is a self-limited process, and we have to. So that's why we have to diagnose Kawasaki disease as early as possible, and we have to treat the disease with IVIG as early as possible within 2 weeks, because after 2 weeks the process is irreversible, and there's a this it is progressively destroy the arterial wall into the adventitia, causing aneurysm, and the type of aneurysm is saccular aneurysm occurred in necrotizing arteritis. Now the chronic vasculitis. Now the chronic vasculitis. It begins in the first 2 weeks after the fever. That means after 2 weeks, this process starts, and there is infiltration of the lymphocyte, plasma, neutrophil with few macrophages. In this is the irreversible stage, and this stage they may cause fusiform aneurysm, and this process and this stage is entered to the third stage and causing stenosis. And the third stage is luminal myelofibroblastic proliferation. That means there is a proliferation of the muscle layer, and there is a causing stenosis. Now, what are the different types of Kawasaki disease? So, Kawasaki disease is divided into three types. One is typical or complete Kawasaki, one is atypical or incomplete Kawasaki, and one is recurrent Kawasaki disease. So, what is the definition? I will discuss later on. Now, typical and atypical is differentiated on the basis of number of clinical features. So, number of clinical features is the differentiating point between clinical, typical, and atypical Kawasaki disease. Now, what are the clinical features? These are the clinical features. There are huge different number of clinical features, but we remember only the 5 clinical features is very much important, and it is in the diagnosis process. The Kawasaki disease has only diagnosed by clinical features, not by any investigation. So it is diagnosed by exclusion, and it is diagnosed only by clinical manifestation, not by any other investigations. Investigation is needed to diagnose Kawasaki disease, but it is not very important, and it is not in the criteria to diagnose Kawasaki disease. So what are the clinical features present in Kawasaki disease? The clinical features are fever with conjunctivitis, cervical lymphadenopathy, oral changes, rash, and extremity changes. These are the clinical features have to be there in Kawasaki disease. Now we elaborated one by one, and first is a fever. So fever is typically high spiking fever, and it is more than 39 degree to 40 degree temperature, and it is remittent in nature. In the absence of appropriate therapy, fever continues for 1 to 3 weeks, and fever is usually resolved within 36 hours after IVIG infusion. So, if after IVIG infusion the fever is not subsided after 36 weeks, that means the child having Kawasaki disease, IVIG resistance Kawasaki disease. Now, the conjunctivitis. The conjunctivitis is mainly bilateral and also non-exudative bulbar conjunctivitis with limbal sparing. So that means the limbus is not involved in Kawasaki disease. There is a bilateral bulbar non-purulent conjunctivitis with limbal sparing. That means the limbal area is not affected in this disease. So the limbal sparing, this is the limbus part, this limbus is sparing, and there is a conjunctivitis, but it is non-purulent in nature and it is bilateral. It's very much important. There may be some features of anterior in some patient, but it is not for every patient. So only remember there is a bilateral non-purulent bulbar conjunctivitis with limbal sparing is very much important to diagnose Kawasaki disease. The first features is conjunctivitis. Second features is oral changes. That means there is crackle lips and there is a red tongue. There is a crackle lips and red tongue. This tongue is also named as strawberry tongue. So if any question is shown the picture and also said there is a strawberry tongue, so think about Kawasaki disease. So there is a crackle lips, peeling of the lips, and red lips with strawberry tongue is the oral features. There, so if any patient having oral ulcer, so oral ulcer and pharyngeal exudate are not considered as Kawasaki disease. Please be remembered for the clinical practice. If any patient having oral ulcer with red tongue, so this is not a features of Kawasaki disease. So oral ulcer is not a features of Kawasaki disease. Very much important. Cervical lymphadenopathy. Cervical lymphadenopathy is the least common of the above five features. That means cervical lymphadenopathy, the diagnostic criteria is it is always the cervical lymphadenopathy always be unilateral, and there is a the diameter of one cervical lymph node is more than 1.5 centimeter in diameter, and it is mainly present in the anterior cervical triangle. So this is the cervical lymphadenopathy. Now the rash. The rash is mainly the maculopapular rash, and rash appear within 5 days of fever. And this is the rash. It is start from the face to trunk and then the extremities. Rash is mainly extensively and primarily in the trunk and then the extremities, and it is very important. There is the early descomalization is a classic characteristic feature. That means the rash appears first, disappears first with early descomation. The extremity changes. The extremity changes are there is a red, tender erythema on the palms and soles, and also there is swelling of the palmar and plantar erythema, along with there is a edema. That means erythema of the palm and soles with firm, and there may be a painful induration of hand and feet. That means hand and foot are swelled with erythema, red and tender. And after few weeks of treatment, after few weeks of the disease goes, there is a so after 2 to 3 weeks there is a periangal desquamation. So periangal peeling, that means desquamation of the finger and toe begin with a periangal region after 2 to 3 weeks of the fever. And at the last features of the disease is there is a Bewes line. So it is happened after 1 to 2 months after the fever subsided or onset, and these are deep transverse groups across the nail bed. So Bewes line is also features of Kawasaki disease. This is the last and the late features of Kawasaki disease is a Bewes line. Now other features of clinical features of Kawasaki disease is there is a chance of myocarditis, pericarditis, or vascular regurgitation. There is a coronary artery aneurysm, and there may be aortic root enlargement also may be present. The respiratory symptoms are There may be peribronchial or interstitial infiltration if you do a chest X-ray. Musculoskeletal features are arthritis or arthalgia. Pleocytosis in the synovial fluid. So, if a patient having fever with arthalgia and the arthalgia is not subsided after giving antibiotic, or the swelling is not subsided after giving antibiotic, then always think about Kawasaki disease. The gastrointestinal features is there may be a increased chance of diarrhea, vomiting, and there is maybe a chance of pain abdomen due to gallbladder hydrops. So this is also MCQ. If a patient having Kawasaki disease, there may be a chance of pain abdomen, and the pain abdomen is mainly due to gallbladder hydrops. There is a nervous system involvement, and the child is extremely irritable. So any fever patient is irritable, but the Kawasaki disease, the patient is extremely irritable more than the normal patient. That means when the fever has come, the child is irritable, and the fever is goes all, then also the child is also very much irritable. So because there is irritation in the brain, there is a chance of aseptic meningitis. This is also MCQ. So Kawasaki disease is one of the most common cause of aseptic meningitis. Is in my previous video I have said that the most common cause of aseptic meningitis is partially treated meningitis, and after that mumps, and the most and Kawasaki disease is also a most common cause of aseptic meningitis. Genitourinary symptoms are the child may suffering from aseptic pyoluria. So aseptic pyoluria is one of the features of Kawasaki disease. And the most common cause of aseptic pyoluria is tuberculosis. And erythema and induration of the BCG inoculation site. So if a patient having fever with BCG scar induration and erythema, then always think about Kawasaki disease. So in your clinical practice, always try to see the BCG mark, because in BCG mark, if there is a swelling in the BCG mark after fever, then think about the child may suffering from Kawasaki disease. Now, how to diagnose Kawasaki disease? As I said, it is mainly diagnosed by the clinical features. So, what are the clinical features? These are the 5 clinical features. So, to diagnose Kawasaki disease, the patient must have fever for more than 5 days. So, fever more than 5 days have to be there, and any 4 of the 5 critical features, if present, then the child having suffering from typical Kawasaki disease. That means non-purulent bivalvar conjunctivitis with limbal sparing, or cervical lymphadenopathy, or oral changes, that is crackle lips, strawberry tongues, rash, that is macular rash, on extremity changes, that means palmar plantar erythema with swelling of the hands and foot. So, if 4 of the 5 clinical features along with the fever is present, then the child is suffering from Kawasaki disease, typical Kawasaki disease. But if there is less than 4 criteria is present along with the fever, then we diagnosed Kawasaki disease as atypical Kawasaki disease or incomplete Kawasaki disease, and we then need the echocardiography finding and also the laboratory findings. To diagnose incomplete Kawasaki disease, if a patient having fever with more less than 4 clinical features with compatible laboratory finding is there and echocardiography finding is there, then we think about the child may suffering from incomplete Kawasaki disease. Now, what are the clinical features and the what are the echocardiography and the laboratory features? I will discuss in this flowchart. That means if any patient comes to your chamber or in your practice having fever for more than 5 days with 2 or 3 compatible clinical criteria, as I diagnosed, as I tell in my previous slides, or the child having fever more than 7 days without any clinical features, then we do the laboratory testing. First, we do ESC, the CRP, and the ESR, and we do all the investigation like CBC, CRP, ESR, and all the other tests to rule out any infectious cause. That means dengue, IgM test, NS1 test, MP malarial test, Widal test. If all the infectious cause is ruled out, then we have to see the CRP and ESR. If the CRP is ESR less than the normal value, less than, that means CRP is less than 3 and ESR is less than 40, then the child is not suffering from Kawasaki disease. That means ESR and CRP low, then the child is not suffering from any Kawasaki disease. Now we have to, and then we diagnosed the child suffering from other disease than the Kawasaki disease. But if ESR and CRP is high, then we do another blood test like LFT and also the serum albumin test and urine test, urine culture and routine test. So if ESSCRP is high and in the CBC report there is an anemia for the age, platelet count, that is thrombocytosis. Thrombocytosis is very much important to diagnose Kawasaki disease. So if more than, and thrombocytosis is only seen in Kawasaki disease after 7 days. So less than 7 days, there is a there may be thrombocytosis or may not be thrombocytosis. That means platelet count may normal less than 7 days in a patient of Kawasaki disease. But after 7 days, the patient must have thrombocytosis if child is suffering from Kawasaki disease. This is very important. And albumin is low. There is a elevated ALT in LFT and counts is also high. That is more than 15,000 with pleocytosis. And the in urine we found more than 10 WBC in high powerful microscopy. That means aseptic pyuria. So if any three of the six clinic laboratory finding is positive, along with fever and along with fever for more than 2 to 3 days with 2 to 3 clinical signs is comparable, then we treat or diagnose the child having incomplete Kawasaki disease. Or if the laboratory test is negative, but the child having fever for more than 5 days with positive echocardiogram, that means echocardiogram shows there is a coronary aneurysm, then the child is diagnosed as incomplete Kawasaki disease, and we have to treat the patient with IVIG. So this flowchart is very much important. What do you mean by recurrent Kawasaki disease? That is, if there is a repeat episode of complete or incomplete Kawasaki disease after complete resolution of the previous Kawasaki disease, then it is called recurrent Kawasaki disease. And the treatment is also IVIG with aspirin. So, in our clinical practice, if a patient having low ESR, low CRP, or normal ESR, normal CRP, or platelet count is normal after 7 days, the child is unlikely to have Kawasaki disease. And also, if there is a WBC count is low and lymphocyte is predominant, then the child unlikely have Kawasaki disease. Please remember this point. Now the laboratory finding, as I say, there is a leukocytosis and there is a neutrophil predominance. The acute phase reactant, that means ESR and CRP, have to be high in Kawasaki disease. The ESR is mainly elevated, and this ESR is also high after treatment of IVIG. So after giving IVIG, the child have also high ESR, and the ESR count is decreased to normal value after few weeks from the treatment. So that means ESR during the follow-up is not used to assess the response of treatment with with IVIG. That means if we treat the patient with Kawasaki disease with IVIG, that clinical features will subsided, and also the laboratory finding which is decreased after successful treatment of IVIG is the CRP, not the ESR. That means ESR will not return after successful treatment. It is returned after few weeks from from IVIG treatment. So that means it is not a marker for the treatment success. The treatment success is the marker of Kawasaki disease is CRP. That means CRP normalizes more quickly than the ESR. That means it is a marker of inflammation after treatment of acute illness. So if the CRP comes to normal limit after treatment of IVIG, that means the child having the treatment with IVIG is successful. The thrombocytosis is very much important in for the diagnosis of Kawasaki, and the thrombocytosis occurs after 1 week, and it is normalized after 4 to 6 weeks of the treatment of Kawasaki disease. And there is a sterile pyuria, as I said. The most common cause of sterile pyruvia is tubercular UTI, and the second most common cause is Kawasaki disease. The most common coronary arteries are involved in Kawasaki disease, and there is a coronary aneurysm occur in Kawasaki disease, as I said before. And the most common coronary artery which is get involved in Kawasaki disease is the proximal lat. That means left anterior descending artery, and after that there is a proximal RCA. That means right coronary artery, and after that there is a LMCA, that means left main coronary artery. After that left circumflex artery, and after that distal RCA. So these are the coronary artery which get involved in Kawasaki disease. The most common coronary artery which gets involved in Kawasaki disease is the proximal lat. And in the echocardiography, we have seen the coronary aneurysm, and it is the coronary aneurysm is now diagnosed after the Z score. So Z score is very much important to diagnose coronary artery aneurysm, and by the Z score, the coronary artery aneurysm is divided into three parts. That is small aneurysm, medium aneurysm, and large aneurysm. The small aneurysm means if the internal diameter is less than 4 millimeter in diameter, or the Z score is 2.5 to 2. That means Z score is very much important to diagnose coronary aneurysm in Kawasaki disease. If the Z score is more than 2, that means the child is suffering from Kawasaki disease and it is significant for coronary artery aneurysm. If Z score is less than 2, that means the child is not having some any abnormality in the coronary artery, and there is no dilatation and no involvement. The dilatation is only after when there is a more than 2 Z score, and if Z score is less than 2, that means the coronary artery is not involved. And small aneurysm means the Z score is more 2 to 2.5 to 5, or the internal diameter is 4 millimeter in diameter. This is also MCQs. The medium aneurysm means the internal diameter is 4 to 8 millimeter in diameter, or the Z score is 5 to 10. And the large or giant aneurysm means when the Z score is more than 10 and the internal diameter is more than 8 millimeter. Now, what are the differential diagnoses? The most common differential diagnosis of Kawasaki disease is if the child having some viral infections like adeno infection, entero infection, or measles, or Epstein-Barr virus, or cytomegalovirus, or some bacterial infection, that means Rocky Mountain spotted fever or scarlet fever, or there may be child suffering from meningococcemia, or there is a rheumatic disease like activity, that means the child is suffering from systemic onset GIA, or the child having toxic shock syndrome, or staphylococcus scarlet skin infection, or Steven Johnson syndrome. So these are the differential diagnosis. Now come to the treatment of Kawasaki disease. The treatment of Kawasaki disease is mainly IVIG. The drug of choice for the treatment of Kawasaki disease is IVIG, and along with this, we give aspirin. Why aspirin is given? Aspirin is given to decrease the chance of thrombosis and decrease the chance of formation of platelet clot. And the IVIG is given to decrease the inflammation. So the dose of IVIG is 2 gram per kg. It is single dose and run to over 10 to 12 hours. And along with this, we have to give aspirin. So if the treatment is not successful after giving IVIG and the fever is not subsided after 36 hours of giving IVIG, then the next adjuvant therapy we can add is corticosteroid or infliximab or etanercept. That means the biologicals we can add if the child having IVIG resistance. So IVIG resistance Kawasaki disease is diagnosed as when the fever is persist for at least 36 hours after the end of IVIG infusion, then it is called IVIG resistance. And the treatment for the IVIG resistance is we give second dose of IVIG, and after the second line of treatment is IVIG with steroid of, that means prednisolone, or we can give infliximab. Now come to the follow-up of Kawasaki disease. That means what is the follow-up of Kawasaki disease? Coronary aneurysm is the most common complication of Kawasaki disease. So echocardiography have to be done as early as possible when you diagnosed a patient having Kawasaki disease. After that, you perform again the echocardiography in follow up after 2 to 3 weeks of illness. If the results are normal after 2 to 3 weeks of giving IVIG and echocardiography show the result is normal, then repeat the echocardiography after 6 to 8 weeks of illness. Then, if the initial or any result is normal, then you can do again perform echocardiography after 1 year. If any result comes abnormal, then we have to do repeated echocardiography depending on the size of the aneurysm. And if the report is normal, then we can do echocardiography after 1 year. And we can do also the lipid profile. This is the follow-up. That means we have to do the echocardiography at the time of diagnosis after 2 to 3 weeks, and after, if the result is normal, then repeat echocardiography at 6 to 8 weeks of onset of fever. And after that, if the reports are come normal in 3 setup, then we can do again a repeat echocardiography at 1 year of age. If the report is abnormal, then we can do echocardiography repeatedly depending on the size of the dilation. So this is all for Kawasaki disease. Please remember, this is the most common acquired heart disease in children. This is the most common cause of medial vessel vasculitis in children. This is the most common cause of myocarditis in children. This is the most common cause of vasculitis in children. This is the most common cause of coronary aneurysm in children. And Kawasaki disease, the treatment of choice is giving IVIG, and echocardiography is the investigation of choice to diagnose the coronary artery aneurysm, and the Z score is the investigation of choice to diagnose coronary artery aneurysm and classify the different types of coronary artery aneurysm. All the clinical features have to be there in typical Kawasaki disease. In atypical Kawasaki disease, less than 4 clinical features along with the fever have to be there. Please be remember, Bewes line is the last clinical sign of Kawasaki disease, and thrombocytosis is seen after 7 days of Kawasaki disease. After IVIG, the fever have to be subsided within 36 hours of giving IVIG. Thank you.